All right, welcome everyone to the latest edition of the AMSSM Sports Economics webinar series. I'll be your moderator for this evening. I'm Edward Smith. I'm academic sports medicine physician, sports medicine faculty at the University of Minnesota. And it's my absolute pleasure to be here tonight to discuss our AI in the clinical research and education setting. We have two wonderful speakers that we have tonight that I'll present here in a moment. Before we get started, just a couple of housekeeping items. If everyone can, as we go along, make sure our mics and our mics are at least muted. So there's no feedback or anything else on the webinar series. And also remember that our question and answer section, we'll keep that until the end. If you have anything as we go along that you want to pop in the chat, by all means, go ahead and put it in there and we'll read that out later. And then last but not least, we have these sessions recorded so you can rewatch them on YouTube, or if you missed tonight and you want to find out more about this awesome topic, you can go to the AMSSM's YouTube and the sports economics subsection and see all the videos from the past as well as this one. So without further ado, let me introduce our speakers tonight. So-Young Oh, MA, MS. So-Young is the Director of Digital Learning of the Digital Learning Division at the Institute for Innovations in Medical Education at NYU, Grossman School of Medicine, and NYU Langone Health. In her role, So-Young spearheads technology-enhanced educational initiatives, leveraging her expertise in data-driven digital experiences, instructional design, and technology-enhanced medical education. She also leads student focus groups, faculty development programs, AI promptathons, and design thinking sessions on emerging technologies. So-Young teaches curriculum design in the Master of Health Professions Education program and actively advances research and scholarship. Her work has been presented at AAMC's Group on Information Resources, also known as GIR, Group on Educational Affairs, and Medbiquitous meetings. She currently serves as the National Chair-elect of the AAMC's GIR, with an MS in Informational Sciences from the University of Grenoble in France and an MA in Educational Technology from NYU. She is currently pursuing her PhD in medical education. And our other speaker tonight is Dr. Jason Matuszak, MD Fellowship or Fellow of the AFP and Fellow of the AMSSM. He's also the Chief of Sports Medicine at Excelsior Orthopedics in Amherst, New York, a team physician for the Buffalo Bisons, and a clinical assistant professor at the University of Buffalo School of Medicine. He's board certified in family medicine, sports medicine, clinical informatics, and healthcare administration, leadership, and management. So without further ado, enough of me speaking. I'll turn the floor over and we can get this thing started.
Great.
Yep, we can see
Okay,
it.
so this is my disclosure. I'm employee of NYU Grossman School of Medicine, and then as Ed said, I'm national chair of WAMC's GIR group, and then I am PhD candidate. So today I'm going to cover, we are going to discuss these three talking points. The first is we are going to discover the evidence base and current state of generative AI in clinical education, and also we are going to explore the use cases of generative AI in clinical medicine, and we'd like to we can see when to use it and then how to use it. And finally, we will discuss the challenges and ethical considerations of implementing generative AI in medicine. So with that, let's start. So I have to disclose also this, I created this image using ChatGPT 4o. So I'd like this is a small group, so I'd like you to share in the chat, how you use generative AI, and so that so I can adjust my talk. So I'm gonna just look at the chat, and if people can write how you use it, it would be great. The other day I was talking with someone, and then in a national meeting, and one residency program director was wondering if some MSPs would be written in using generative AI. Insurance correspondence, yes. Okay, that's so funny. Okay, with that, let's talk about generative AI. So how does it work? So the first thing is like generative AI gathers all the text like on internet, and then it converts those text into numbers, so that we call it embeddings. And then we put those like numbers like close by meaning. So those are meaning space. So we regroup all those numbers, and then finally we put the predictions like, okay, like after these three words combination, or like not words, like the numbers combination, comes the other combination. So it's a really complicated network, and then the predictions. So that's why it's generating the new content and code or text or images, not um, not searching for the exact like uh, exact match. So let's look at like with that. So this is the prediction part. So it's a let's let's talk about like how the like generative AI, something like ChatGPT, is different from Google search. So on the left side of your screen, there it is generative AI, and then right side is Google search. So Google search retrieve the text or like images or knowledges that are existing in the internet. Generative AI, as we just talked about, it predicts what would come. So, for example, like if we write down like in the dark, like night, monsters, and then after that, it predicts come or like a eat or so something like that. So it generates, and so it creates text, images, music, videos, and it's a conversation. On Google, once you like put the search keyword, and then you get the result, and then you cannot say, oh, I didn't mean it. You have to restart that search. And with generative AI, it's a conversational, so you can say, no, this is not what I meant, so you have to revise this, or you can just add, no, I meant this. So that is conversation. And then like both of them could give you incorrect or irrelevant information. So medical students use it for summarizing learning materials, because in medicine the learning materials, learning content is huge. So sometimes they want to really like summarize all those huge materials, like to synthesize the content. And then they also these days generate practice questions for step 1 and 2. And also they practice virtual OSCEs by creating clinical vignettes online, like on generative AI. And there are also commercial products. And look for clinical evidences using open evidence and up to date. And they create Anki cards. They look for academic help, so tutoring like HP bot, and they plan vacation, write emails, and review manuscripts. And patients might use like this. So I created a completely fake blood test result on the right side. And so I'm going to get out of my slide, and then I will bring my GPT here. So I'm going to share my GPT. And then here you can see add photo or files. And then I go like add photo or files. And then I put it here like blood test. So I put it like as a patient, I got the blood test, and then I don't understand what it is. So I say like explain this. And then it is thinking, and then let's see. And then so it says like glucose is normal, fasting blood sugar, and then this is it, and it interprets what it is it. And the bottom line is all values are within the normal reference intervals, indicating normal glucose metabolism, kidney, liver function. So your patients might do that also. Let's go back to the slide. So that's one case that how people can use this. And then after that, so this is another one. So like these days we can get the radiology images through like the app. And then what happens is some students also, but patients, what they can do is, oh, sorry, I'm gonna go back to my ChatGPT. And then I'm gonna upload that radiology images and then add photos and files. And then I'm gonna put that X-ray and then what is this? And it will read this image. I'm not medical doctor, so I'm not sure if like it is reading correctly. So please read, and then if it is completely wrong, let me know. So it says there is an anterior humeral line and then posterior fat pad sign. And take home is like the anterior humeral line misses the capitalium and raises posterior fat pad and extension type, fracture. So I'm not sure if it is correct, but your patient might like come with that idea to you and say like, I look up ChatGPT and then ChatGPT said this. So that is another like example that people use. So otherwise, like in clinical side, physicians, how we use this these days. So as some of you are maybe piloting or using in your setting, in your clinical setting, Abridge or ambient AI scribes. So it means that you have a machine, an Epic, integrated in Epic, and then it records your conversation with your patient, and then it summarizes the note. So it creates like history gathering, or it summarizes the like patient encounter note. The advantage of that is you don't need to really like doing this, like using your, like you type and then you try to look at your patients and you type. And from patient's perspective, like from my perspective, I realized that I used to see a lot the profile of my physician. And now I can really like talk, face to face much more. So that is it, the clinical note. And then the study says in this qualitative study, ambient AI scribes were found to positively impact physician workload, work-life integration, and patient engagement. And the other one is like quick help, like up to date. Recently, I think it was this May, launched natural language model. So it means that you don't need to write like exact treatment or exact diagnosis. You can just say like, I have an elderly patient who has this symptom, and then I'd like to treat that. And then it'll look up to date database, not others, the up to date database, and then it will summarize the up to date content. So up to date type of AI is not looking outside internet. It is like the source is controlled. So up to date it will look at only up-to-date source. So it will the provide the generated summary is very accurate. And then the other one in the literature review, if you teach and then or if you want to look up some evidences, there is Cite AI or open evidence that you can look at um, the citation, and then open evidence is really like specialized in medical journals. That being said, none of these look at all the all the databases. So I would always like double check somewhere else if there are other articles. So another thing is like what physicians can do is you can create patient education materials. So what I did was I was on the Gemini, and then I asked like generate easy to understand sprain care at home for my 70-year-old patient. And then it says, okay, here is an easy to understand. And then it started like, remember the rice, and the R is for rest. And then it was generated within, within 30 seconds. So if you want to generate like a patient education material, and then you can use this as a draft, and then you can edit that, and then you can share that with your patient. And the other one people do these days more and more with advanced AI is like trying to get diagnosis. So differential diagnosis is like a generative AI model provided the correct diagnosis in its differential in 64% of challenging cases. So this was one of it the left side, it was in a study in 2023 about accuracy. And then 2025, there was a systematic review that showed that for the overall physician, like there was no differences between the ChatGPT and overall physician accuracy. However, for the expert one, like still human expert physician do much better job than the generative AI. So it is not really experts enough, but it's getting better and better also. So some physicians use generative AI to look up and then to create very quickly like a differential diagnosis. And in medical education and research, like use cases include we try to improve our feedback skills. For example, uh, in the medical round, in the clinical rounds, what we do is we go outside of like in the hallway and then say like, oh, this residency is a very like a they completely missed an important part of patient history gathering, and I'd like to provide a constructive feedback without hurting their feeling. How can I phrase this? And then, you can just talk to the generative AI on your phone, and then it will edit really a very nicely written feedback and or like oral feedback. And so you can use that for that. And then also you can evaluate your own teaching materials or your slides. Like you upload the slide and then say, this is a setup slide that for this type of audience, and then please give me the feedback, and then it gives a great feedback also. And it generates multiple choice questions or like open-ended questions or survey questions very nicely. And it can preview also our manuscript. So recently, I use the internal GPT because at NYU Langone Health, we luckily have the internal GPT. And so I could upload like safely my manuscript. And then I wrote like, please review this manuscript as a, scientific peer review journal editor. So that is something that we can consider. I wouldn't like change 100% like to to respond the ChatGPT or Gemini's review. However, it helps a lot. And then a recent also study showed that uh, generative AI review is as good as human reviews. And also it it also helps us review data analysis methods and then generate data visualization. And with that, how I use is I use to generate meeting notes, summarize conference presentations into themes, and also generate USMLE style questions, create virtual patient cases, clinical vignettes, create infographics, and also generate practice questions and write emails like many of you review manuscript, compare my notes on journal articles, and create prioritized to-do list. So I sometimes just record or I talk to GPT directly while I'm walking to work. And then today I have to do all these things. And then and my goal is this. And after that, like I say, generated a to-do list with the high priority and medium priority and low priority. And that's something that it can do very well. And then write Excel formulas. We sometimes don't remember how to write, Excel formula. And then it writes Excel formula beautifully. And also like the same way it writes R like programming code or other programming codes like Python and like HTML. So, and create draft presentation slides. So if you have like a maybe new 365 like Microsoft PowerPoint, you have design feature that you can use also, or in Copilot also, you can draft presentation slide very easily. With that, also, you can also create podcast for your notes. So one of the example about the images. So as you can see at the bottom, this is the prompt that I use, generate an image of dermatology resident in clinical learning at NYU Langone Health. And then left side, it is Copilot, middle Gemini, and right side is GPT-4o. It is good if you look at very carefully, maybe like some of the tools are not completely correct. However, it got much better. So now like I think 6 months ago, 7 months ago, if we create the images using generative AI, the texts were like all wrong, and then people had like 6 fingers, but it doesn't happen now. And I wouldn't use it though, like to create, cell images or medical images, other like pathology images. And this is another like cool tool that I use personally is it's called Google Notebook LM. So what you can do is you can add different sources and then you can create like summaries and then you can create also podcast audio and then you can interact with your own sources. So I'd like to show you very quickly how it looks like. So let me look at the Google Chrome. So it looks like this. So you can create create new, or you can I can show this one. I found some like YouTube videos of this group. So what I do is I add here, and then you can upload PDF text file, but also you can you can just choose your Google Doc or Google Slide or like public facing website or YouTube videos, or you can copy and paste text. So what I did was I copied and pasted YouTube site, and then also I put the AMSSM website. And then we have 3 resources, and you can just choose like one of the resources and then say like create key points. And it creates key points only using this this video. So this is it seems fellow online lecture series, and then it has speaker background and other things. And then what you can also see is it references where you can find this information in this particular source. So if you are um, concerned of the hallucination, this is a good way to control your source. So this will look at only the source that you put, and then you can like have a chat with your own source. And then you can here on the right side, you can generate the podcast. So if you have your own PowerPoint slides or your talk, you can upload that, and then you can generate a very short like basic PowerPoint, and then you can like you can share that with your residents. What I do is I go to conference and then I hear many like presentations, and then I write notes, and then I just put those notes here, and then I create the podcast about that. So I spend a lot of time on the subway, so I listen to those podcasts. Let's go back to the slide. And so with that, I'd like to share some tools and tips. So there are like this is uh, from a website, a quick guide, and you can look at on the right bottom, like the source. And this is the comparison of 3 major generative AI tools like Claude, Gemini, and GPT. So as you can see, like advanced models, and then like voice, image input, code execution, all those 3 are good. Claude, if you use Claude, like I wouldn't, like the free version doesn't generate the images. So for images, like it's much better to use GPT and Gemini. And with that also, so visual content is, as you can see, Claude is not good, but DALL-E, like using GPT is good, also Gemini is good. The good part of Claude is Claude does not train future models on your data. And so by default, it doesn't doesn't use your data to train their model. Gemini and GPT, like it will use your data. So that's the big difference. And prompting wise, so prompting is like how you talk to generative AI tools. So basic prompting principle is be specific. So like clearly state the context and then what you want. So for example, you can say you OpenAI will act as an experienced administrator in US sport medicine like office, or like you OpenAI will act as a very experienced editor, something like that. And then give the context is if it is like for your manuscript, you can say this is for academic medicine, or you can say also this is an email to my mother-in-law or something like that. And then the other one is define output style. So you can say like soap notes, like you want the result in soap note style, or you can say like create a table, or you can say also, you know, create like slides, something like that. And then set the tone is be factual and to not be creative. You can say that. And also the other thing is use example. So it's a machine. So if you provide an example, like I want this type of result, you can upload that example, that template, and then it creates really good result. I can see a chat. Oh, thank you. So pass to a powerful prompt is like a give the context, be clear and specific, ask for abundance, and then use branching. So like the third one, AI doesn't get tired, and then AI doesn't get upset. So you can ask questions over and over again and then say, this is not what I want. And it takes time, but it gives better result. So let's talk about ethical consideration a little bit. So the first one is hallucinations. Hallucinations is one of the big issue of generative AI. That being said, generative AI is created to be creative. So like it is sometimes I feel like generative AI sometimes it acts like 5-year-old child. So instead of saying I don't know, it says it creates something. So that's the hallucinations. It's much better, but like still for references and then for medical information, I would double, triple check. The second one is lack of evidence. there are more and more studies coming out. Like you can look up JAMA and other medical journals about the effect and evidence of AI. However, often the study condition is very controlled. So we are waiting for more evidences about that. And accuracy is, how do we define the best AI? So which one is better? Like if you ask the same question in Claude, in Gemini, and GPT, and Copilot, the answers could be a little bit different. So that's another way also maybe compare the results. And also what works for one health system, one doctor wouldn't also like work for others. And it's like for now, it's still the first generation, second generation maybe of the generative AI, but it's getting much, much better. So uh, that is it. And the last consideration is like avoid Google-like search, but let's really use it to strategic thought partner. Uh, I suggest we use it as an assistant and as a very capable assistant who is very patient also. So use it, but you are not gonna like copy paste your assistant work. So it's the same thing. Use it as a draft and then ask other experts' opinion on the result. And then use your opinion also and your expertise. So this is it. This is my part. Hopefully it was helpful. And I'm gonna stop sharing.
Absolutely. So Young, thank you so much for that. Very informative. Nice to see that you also had a graph of different generative AI and their strengths as well. And I agree with what Marcia put in the chat also about controlling the source of the AI information. So thank you for that. Thank you so much. Um, Dr. Jason Matuszak is next. Dr. Matuszak will be talking about some of the clinical applications of AI as well as he is using it and how he is seeing that in his own practice. Dr. Matuszak, are you ready?
I think we're good. You can see my slides, right? You good?
Yep, slides are good.
Excellent. Thanks, Ed. Okay, so yeah, I mean the applications between using AI and the clinical world and medicine are just profound. And I want to dive a little bit more into some of the practice, efficiency, and economic sustainability portions of it that are going to impact a lot of our physicians. And really, even though a large number of our members have moved towards employed models, I really look at using tools like artificial intelligence to allow our physician members to actually be able to be independently practicing primary care sports medicine physicians at a much higher rate than what we've been able to in the past. Most of the tools that we're going to look at are going to be things that can enhance your ability to practice independently without feeling the need to have the employer model to be able to help sustain you, because it can help manage your practice in addition to helping you get through your day in a much more efficient manner. So we're going to dive into this a little bit. So we'll evaluate the economic implications of adopting AI tools in the sports medicine practice, identify practice management areas where AI improves return on investment and operational efficiency, and employer implementation strategies that mitigates cost and workflow disruption. Why AI now? Inflation and staffing costs. It's difficult finding staff. It's difficult training staff. Many times you're having to retrain staff with a high turnover rate. Sometimes a year or two is all that you have with individual people. And so we're all looking for a way in order to be able to streamline the work that we're doing inside the office and make it less work for the people that are working for us. There's a documentation burden and fatigue. Obviously, the physician community has been burdened by this over documentation burden, and what we're really looking for are methods that we can use to help reduce some of that and help improve the fatigue that we're experiencing. Value-based care pressures. Now, implementation playbook, we want to focus on, early on, low-cost pilot models of using AI. How can you implement it in a way in which you can trial things out inside your practice, look to see what's going to be working for you, and then make iterative adjustments as time goes on. We want people to measure what actually matters. Is your return on investment in terms of a time savings, a billing uplift, patient satisfaction, decreased contact time? Is it actual FTE, full-time equivalent employees that you're saving either time or effort from? And then we want to make sure that we're looking to avoid the pitfalls, looking at things like EHR gatekeeping and assessing our AI tools to make sure that the electronic health record vendors are playing well with different tools that we might be looking to use inside of our practice to help with the implementation of AI. We want to take a look at data privacy, and then, as we've already heard about, hallucination risks that are important inside of a medical practice too. The economic levers of AI and practice management, again, we're looking to reduce staffing overhead, visit time, or missed care coordination, and at the same time, increase our throughput, patient satisfaction, and reimbursement potential. Now we're going to take a step to the side here as we talk a little bit more about how to implement an AI tool inside your practice. And many of you may have be very familiar with one of these. This is just a Gantt timeline, which allows us to be able to evaluate the steps that might involve in any of these AI tools that we're going to be talking about. Like what would actually be involved from a timing perspective, and trying to determine, and as we're going through the various tools, I tried to include like a reference number of contact hours for a physician provider looking to implement one of these solutions. But these are just really rough estimates, and it's going to come down to your unique situation, and everybody's in a different one. But the same components of this Gantt timeline are going to flow through for any of these tools that we're going to be looking to implement, just like any other practice management project that you're looking to implement. And you do start off by a needs assessment or an opportunity assessment. Is there something there that you're not doing as well as you could be with one of the tools that's out there? You go through a vendor selection process where you assess the marketplace. You look to see the different vendors that are out there. You get presentations. You listen to their pitches. You assess how well they would work in your unique situation. You do your own IT and compliance review. Again, depending on the size and makeup of your practice, these things can be very variable. Look at workflow customization. So, how would you change your existing workflow to make sure that this AI tool that you're trying to implement fits inside your clinical practice? You try to determine your staff training time and your pilot time, and then you have your go live period. And your go live period, there's a lot of buildup for this very, very quick instance that occurs, because everything that follows after that is monitoring and iteration. So after you've gone live within one of the AI tools, how do you assess the ongoing feedback and get into a feedback loop where you're seeing where you're having successes, where you're not reaching the objectives that you're trying to reach, and how do you make iterative adjustments moving ahead? The main areas that we've looked at translating AI into practice with where they are currently, and I say currently with an eye towards the past, really, because almost everything that we're talking about is already old news. Everything that we're saying is current is probably already 3 to 6 months old, because the pace of progress in this field is just moving so quickly. But we've got things like clinical chart documentation, personalized care summaries, symptom triage, follow-up action automation. These are things that are a little bit more mature technologies, things like inbox management, patient message generation, chart review summarization. These are things that are, again, developing these technology. Care escalation, and then some of the administrative stuff, benefits verification, and assisted diagnosis, a little bit more nascent technologies are still developing. But these are all different things that you might think of implementing inside your clinical practice. Today, we'll focus on just a few of these just to get things, just to get the information in front of you. For those who were able to attend the annual meeting, there was an excellent presentation done on the use of ambient AI scribes inside the medical practice. Now, AI scribes that are ambient listen to the visit and draft the structured note. These are working best for things like history and physical exam, well for things like your assessment at your plan. It's not working as well for creating orders, and these are things that are still being worked on. But importantly, what we have to think about is the way in which these can enhance your practice, but may not solve all of your problems. So, for somebody who's never had a good live scribe, an ambient AI scribe versus the provider recalling or documenting in real time, or trying to recall the encounter and then documenting, ambient AI scribes are superior to that. But for people that have had a good live scribe or currently have one, it doesn't replace all of the functions that a human can yet at this point. We're still looking towards the technology being able to do things like in real time sending triages to other members of the healthcare team, being able to generate work notes or school notes in a way in which you're talking about them in conversation, and then they actually come into being. So those things are still kind of a couple steps away from being realistic. And so therefore these types of solutions are very helpful for some providers and maybe less helpful for other providers. When we're looking at the use case, these are the rough numbers that you have to keep in mind. There's a number of different products that are out there. I included on the previous slide a handful that you'll see on the marketplace. You know, when you're going through a vendor selection process, you're going to be getting all of this information, but I've tried to summarize it as best I could to give you a snapshot of what it is. But some of the ambient AI scribes will cost as little as $250 per month per clinician, and some upwards of $1,000 per clinician per month. Obviously, that variance is going to change what your ROI is in terms of your break-even timeline. But for most of our physician members, we're looking at a break-even timeline of just 2 to 4 months. Now, anytime that you're looking to implement a new tool inside your clinical practice, or a new device, or a new technology, you're always looking at, you know, how long is it going to take for you to make back the money that you've invested inside the product and to make additional revenue. And in terms of cost savings, these probably save about a fifth of an FTE equivalent of a person, meaning that, you know, that it's fully not replacing a staff person, but for the individual clinician, it might be saving an hour or two a day of documentation time, and that's a really big deal. And so, you know, that break-even timeline of 2 to 4 months for most businesses is going to be a no-brainer. Really, anything that's 3 years or less is considered to be like something you should do. Anything that's a year or less is a slam dunk, and anything that has a break-even point of less than 6 months, if you're not doing it, you're really costing yourself a tremendous amount of opportunity to enhance revenue inside your practice. Estimated implementation time for the individual clinician, you know, you're probably looking at upwards of 12 to 20 hours per person, and then ongoing regular support for introducing an ambient AI scribe. There's a lot of build-up time leading up to it, you know, where you're working through your iterative process of what is it, how are you changing your workflows, and all of those things that the clinicians are involved in, but also the educating of the clinician about how to actually get the system to work the way that you want it to do, and then looking at how you would implement it and make changes as you're moving. The next use case I want to address is triage symptom assessment. There's several products that I listed here that are on the marketplace. These are chatbots that are designed to collect symptoms pre-visit or aid in triage. And in essence, what you can do is to have your patients go online through a special link in advance of their visit. They can use one of these assessment tools, and it'll pre-populate most of your history for you based on what they characterize in an interactive fashion. So this can eliminate some of the time that your, you know, medical assistants might be doing, or you have an athletic trainer, physician extender that's getting a history. And this will help to improve and make more impactful the time that your staff might be spending with the patient trying to fine tune things. as you know, 70% or greater of our differential diagnosis is based off the history that is obtained. So if we can get a lot of that stuff and start the process ahead of time, it helps us fine tune what it is that we're accomplishing during a visit. Now, these things will help by actually creating a differential diagnosis even before you go in to see a person. And some of the generative AI tools will be able to help with this as well, in terms of helping you make determinations on how to prioritize your differential diagnosis when you go into the exam room. Now, these tools do lack some discernment. There's lots of questions, especially for musculoskeletal topics. I went through one myself, and it was 31 questions to come up with a knee contusion, plus 10 questions on patient demographics that you had to complete. So, they're not necessarily very quick for patients to be able to use, but they are time saving for clinicians and staff to be able to implement. The cost of these are relatively cheap when it comes to AI tools. These roughly $100 per clinician per month, and it helps to reduce that intake workload. Also can help to reduce your phone triage time. So if you have something implemented on your practice's website where you can give your patients through a password protected link access to one of these triage systems, they can go through a phone triage without actually taking up the time of the person in your office who would usually be handling the triages, whether that's a triage nurse or an athletic trainer or a mid-level provider or the physicians themselves. Break-even timeline for this, because of this, is actually pretty quick. We're looking at about a month. And the estimated implementation time is really about 10 hours clinician, and that's an overestimate. These tools would be much more readily able to be implemented almost as a out-of-the-box solution with just some fine tuning to fit into your existing workflows and trying to figure out how to optimize those types of situations. The third one I wanted to talk about was imaging assistance. Now, these are, if you take and have your own images inside of a PACS system, these tools work best. Yes, you can upload any image that you have into an AI software system and be able to get it to interpret it. However, these are medical grade imaging assistance technologies. Many of them are FDA cleared to be able to do assessments, and they can give you, they can start off by flagging abnormalities inside the imaging. They can give you faster diagnosis if it's a high volume or rural settings, and it can reduce scan times as well by using advanced algorithms in order to be able to optimize the images that are obtained in the first place. These are a little bit more pricey, and these are usually geared more towards our radiology colleagues, but can certainly be used in a busy primary care sports medicine practice as well. These are looking at $400 or $500 per clinician per month. Productivity are getting faster reads and fewer missed pathologies. So you can use these just to help overread anything that you're already reading inside your office, just to make sure that you're not missing anything. It doesn't save a lot for the practicing sports medicine physician necessarily, probably just 0.1 FTE equivalents. However, for a busy radiology practice, the savings might be much greater. Because of the high cost and low FTE savings, the break-even timeline's a little bit longer. But still, all these tools are things that, in the less than a year category, in order to have a break-even point, they're all kind of no-brainers that will enhance the quality of the practice that you're providing, and also have a return that's a financial improvement for the individually practicing clinician as well. Estimated implementation timeline 10 to 15 hours per clinician. We have the ability to do rehab and movement analysis. Now, this might be able to offload a certain set of your patients from referring them to physical therapy. And this is different if you have your own physical therapist inside your practice. Maybe you don't want to offload some of the patients off of them. Maybe you're trying to make sure that they're reaching their capacity. However, if you can take people who are more independent exercisers, these tools might be very, very good for you. In fact, there are some tools that will also allow, since this is being done in a supervised setting, that there is potential for reimbursement for some of the programs that exist out there, especially if they're overseen by somebody in your practice who's already a physical therapist. But they do motion tracking and rehab guidance, personalized recovery, and remote monitoring. A little bit more expensive here again. This is about $400 per clinician per month to have this remote rehab movement analysis. It supports PT referrals and remote billing. It saves roughly 0.15 FTEs per provider that's using this, just in terms of not having to educate your patients in real time on the exercises that you want them to be able to do, but also gives you the improved performance of the exercise because they're being monitored in real time to make sure that they're performing the exercises the way that they're being instructed to. Estimated implementation timeline is a little bit longer for these types of products because some of them you're developing your own exercise programs and packets and which exercises you want for which types of medical problems that somebody might have, spending a lot more time on the front end, kind of fine tuning things the way that you would want your patients to be able to access them and do them. Plain language summaries. These are great implementation pieces. These are actually relatively cheap because you can use a lot of off-the-shelf uh, freely available or cheaply available generative AI tools. So if you start off with an MRI report, and this is what an MRI report would look like when you're reading it as the physician who's looking at the radiology read, but you can ask your generative AI tool to interpret it at a sixth grade reading level, and it'll give you a different reading that might be more applicable for your patients. And then your patients might be looking for something that's more simple, like, do I need a surgery? And the tool can help to identify things that might be surgical types of conditions. So, and these um, allow us to be able to communicate medical information in a simplified fashion for our patients without us actually having to go through and try to simplify things at the level that our patients might need. These using the large language models and these patient plain language summaries, roughly $20 to $50 per clinician per month. There are some free solutions. You can use things like open evidence and manually put in the report and get the plain language summary, copy and paste it into your EHR, or print it out for the patient so that they have it. These Because there's a little bit of work involved in generating the plain language summary, you're not necessarily saving a lot of FTEs in terms of providing these. In fact, you might actually be taking more FTEs of staff time to create these plain language summaries. Where you get the savings we anticipate on this is going to be fewer follow-up calls, asking for further clarity, fewer visits for explaining imaging findings. So some people that are really savvy or independent, if they're able to access their MRI report through their patient portal, as well as a simplified plain language summary, that might save them from having to call your office or schedule an appointment to review those same findings with you. Even though there's not much of an FTE savings, because of the low cost of these particular tools, break-even timeline is really pretty quick, about a month generally. And implementation time, less than 10 hours per clinician, is really just kind of figuring out the workflows that you would want, and instructing your staff on how to create these plain language summaries, or the physician themselves understanding how to do it. What other things can you use it for in the office? As we've already heard about some of the large language models. Open evidence has a pro in that it's free for medical providers. Answers are fully referenced from journals and trusted sites. So you'll get less hallucinations, great for answering medical questions. This particular tool, not as creative, not able to handle business use cases at all or as well, just kind of outside the scope, and it'll tell you that. But you can use it for, can you give me a differential diagnosis for this? What's the fastest way to cure athlete's foot? On a diagnostic, these are all things that I've asked it, even over the last week. On a diagnostic ultrasound, I saw a nerve that passed dorsal to the third metatarsal and crossed the foot immediately. What nerve might this be? And then, can you summarize the evidence for eccentric exercises for tendinopathy and develop a patient education sheet, including pictures of exercises for patellofemoral syndrome? And all of these will produce an answer that has references that are peer-reviewed journal references in most cases, or trusted website references, and you can go through and verify those. Okay, ChatGPT, you've heard a lot about already today too. ChatGPT has advantages in that it can do medical questions, but also business and medicine questions, legal questions, and helping you develop other resources and materials. Cost $20 a month for an individual license, and it might hallucinate. But here is one of the use cases that I developed for this, which was helping our phone triage staff be able to determine whether or not they had to be concerned whether a patient had a septic arthritic joint. So can you develop an algorithm a telephone triage nurse can use to determine whether a joint pain might reflect septic arthritis? And here it is: start, chief complaint of joint pain, rule out emergency. And here's your exclamation point, red bullet items that, if it's any of these, then high concern for septic arthritis, escalate to a provider, or recommend an ER urgent person evaluation. Step 2, if it's not one of those, red flag conditions, assess for risk factors. Do they have risk factors? If yes, and joint pain, increased concern, discuss with a provider urgently. And then 3, go if it's not step 1 or 2, then characterize the pain. If it meets the criteria of being monoarticular, constant, rapidly worsening, monoarticular constant, rapidly worsening pain is concerning. So again, that would be somebody that you would want to bring in, but here's how you do your decision support: high concern, escalate immediately; moderate concern, urgent appointment; low concern, routine appointment. So you can go through a whole laundry list of, you can take your top 10 most common calls that you get in through your triage person, and you can develop very quickly algorithms that you can evaluate to make sure that they make clinical sense and then implement in real time. I've asked you to develop office policies, a no-show cancellation policy. So, how uh, ultimately, one of the points I started off with is I want our members to feel like they can practice independently, that they don't need to feel like they need to be in an employed model situation in order to be able to practice medicine. And one of the things that I feel that these tools can be really good at is helping us develop things like policies and procedures without actually having to develop policies and procedures. So here's a no-show policy. You can make sure that once it's created, that it fits your particular needs and your situation in your community. It tells you what to do if you do have to cancel or reschedule. And it even goes so far as to say, we understand that emergency and unexpected situations happen. Please communicate with us. And it goes through this. I've used it to develop business plans. Here's a business plan development that I created. Was somebody wants to start a direct primary care clinic, and what does that business plan look like? And I included in here a QR code for the comprehensive business plan model in case any of you are interested in starting a DPC model. There's your starting off point. But for individuals that are in private practice that are looking for you can use it for looking at return on investment. We're looking at starting a bone health clinic, and we went into one of these models and said, okay, so let's evaluate our use case and let's look at a business plan development. And we can do those things, and I can develop a business plan, and I can go through all those steps. But that's time consuming, and in a busy practice, I don't necessarily have time to do that, but I do have time to fine tune a business plan that's been developed by a generative AI model in order for me to be able to make sure that it makes sense and to implement inside of our practice. There's a few of the details just to give you an idea of what it actually looks at. A few more of the details, including things like success metrics and stuff. So, roadmap to adoption: start with low barrier tools, ones with very low friction, be able to train your staff, and then know how to measure the impact: time, satisfaction, return on investment, scaling through partnerships, and being able to grow these products. Remember that not everything is going to save you time and effort. Generative AI drafted replies to a patient's electronic communications were actually resulted in increased read time, no change in reply time, increased reply length, but some perceived benefits. So these things won't always save you time, but they might enhance the quality of what you're putting back in a method that is in alignment with what patient expectations might be moving ahead. What's next? We'd like to see things like denials management. So, if insurance companies are denying your claims, can these tools go back through your notes and highlight the areas that are resulting in the denials proactively, so that in real time you can get the feedback and make sure that you're checking the boxes that the insurance companies are looking for before you actually have your claims denied? Can you look at prior authorization requests and making sure that your notes are optimized for what they're seeking in the prior authorization? AI and scheduling, there are tools that exist right now already where they are using AI phone systems for appointment scheduling. They're still nascent, but they're growing. And then predictive analytics. Take home points. AI tools are meant to augment the work of the healthcare team. Might not reduce your FTE staff as much as we'd want right now, but they might decrease workload and save time and energy. They should be considered a business strategy, how you can enhance the business that you're putting forth. AI tools are in various stages of maturity. Some are clinically ready, some need much more refinement. Start with the tools to reduce friction and save time, and then track savings, not just features. All right, that's what I got.
Jason, thank you so much for that, man. Your whole talk, especially getting on the return on investment and the breakthrough time, that's great. And it's interesting that, I think at first, because so many people spend time in their electronic health record, you would think that the plain language summary would save a bunch of time, but the implementation process actually increased time. So it's really interesting to hear that. But yeah, thank you both. I think we'll go ahead and turn to the Q&A session now, if you have just a little bit of time here. I guess one of the first questions that I had for you both is, and you both touched on it, but is there any particular, or what would you say some of the biggest challenges that you've encountered in implementing AI, whether it's in the research and education department so young, or even when you're developing it into some of the private practice stuff? Jason, what have been some of the biggest barriers you guys have noticed?
For education and research, it's about the ownership also, so if you don't really control like the firewall, it means the tool is getting better and better, but I like we cannot really upload or like the images or articles that we don't own. So, we have to be very careful that, and then even my own material, if I upload that to the public generative AI tool, it will be used in some way. So that is challenging. So how to really use like private tools.
For me, I would like to see some of the AI tools incorporate more machine learning and real-time interaction with clinicians to really be able to give it feedback to, when you're dealing with, when you're dealing with ChatGPT, you can say, well, I like that, I don't like that. Can you fine tune this? Can you put a different, can you use more technical language or less technical language? When you're using things like an ambient AI scribe, there's not that give and take with it. It's kind of taking what you have, and then if you don't like it, then you're going through and editing it, but it's
Right.
not really having that back and forth conversation that it's really kind of learning, and with something like what we'd like to see in some of these is that, this is the style of my notes. Here's 100 notes or 500 notes or 1,000 notes that I've done before, and please learn my style. And they're just not quite to that capability yet. Hopefully they'll get there.
For sure, for sure. Well, it's also interesting, hearing, I think for the general public, hearing generative AI, it almost seems as though it's lumped into one specific thing. And from both of your talks, you can tell how there's so many different subsections in it, and using what you think is going to be most beneficial for your practice. So that's great. Marcia in the chat asked, with the triage questions, wondering what reading grade level are those typically based in? She's had some patients that are, may have a different level. And or even is there a way to because I think in your example, Jason, you said some of the language stuff was in a sixth grade reading level. Is there a way to even lower that if necessary?
So with the commercially available triage tools, no, those are kind of set at one level, and you kind of answer the questions in an interactive fashion. But that does not really have the ability. So maybe if you work specifically with a vendor who was providing a product, you might be able to lower it, but it'd be lowered kind of across your implementation inside your practice as a whole. Now, if you're doing something like a plain language summary, that you could simplify down as far as you want to. I mean, because then you're
Right.
just taking that and plugging into a generative AI tool, and you can make it much more simple than what we did there, which was just kind of the average reading level. But the triage tools probably not. Now, for your triage nurse, the that demonstration that I included, that you can fine tune that for sure as well. You could simplify the questions that your triage nurse might be asking the patient on the phone when they're doing phone triage.
Absolutely, absolutely. Um, one other question in the chat also. Sorry here. Uh, just from Jordan. Jordan wanted to know if we could weigh in on any tools to assist with chart review, perhaps in conjunction with an AI triage component to assist with history taking.
Yeah, so there's a couple of different tools, and I'm blanking on the names of them right now. Some of them, like for instance, Epic is developing their own in-house that's going to encapsulate what the person's history up to that point, and present it to you. But there's other tools that can work across the entire community. For instance, I work with a regional health information exchange program, and we have a tool that can capture what's been going on across the whole community, and synthesize it too, not just for what's going on in Epic. One of the challenges that we run into is that the systems are not necessarily really able to parse out what might be clinically relevant information for this visit for this body part on this day, and that you might be getting a whole different set of things. Some of your patients you might be seeing, and might have four different workers' compensation cases for six different body parts. And if you're dealing with different workers' compensation cases, you can't have information pertaining to other problems inside the same note.
Right.
And the systems aren't readily able to discern that level of scrutiny yet. So
Sure. Wonderful. Um, one question. So Young, is there any way to ensure accuracy and avoid bias in the generative AI tools when you're looking at it from an education or research standpoint?
The short answer is no.
Thanks.
The
Thank
long
you.
answer is what we can do is you can, it's like an expert also. You ask the question to an expert, how can you say that that is 100% accurate also? So you get the second opinion. So I would get the second opinion, third opinion, like throughout the generative AI tools, and also also ask like human experts also. So that would be my answer.
Makes sense.
Mm.
Well, wonderful. Um, Audience, are there any other questions that we have to throw in the chat? Great. One more question. Jordan asked, are there any tools that assist with referral management? Examples, redirect non-op cases, um, from overload ortho clinic to primary care sports medicine.
that's funny. I'm always trying to send them back the other way. I'm
Yeah.
overwhelmed, and they could use a few more. Uh, Let me think about that. Um, I don't know of any commercially available products right now. However, with the AI implemented phone solutions, one of the advantages that you have is that, humans, when you're dealing with appointment schedulers and things like that, they are either functioning from recall, or they're functioning from their own paper algorithms, paper, so to speak. It's usually some type of flow diagram that they might have. Like trying to figure out who is the appropriate provider to get somebody in with, and they're trying to take into account a lot of different contexts. What's the closest location? Was there somebody they specifically asked for? Is there a body part or something else like that? The AI tools will probably be far superior when it comes to how they are able to parse out stuff that especially with using the if you marry them together with your symptom checker and your triage management piece, and like making sure that somebody gets to the appropriate provider at the appropriate time, and they'll probably do far better than many of the people that we pay to answer the phones because of the difference in the knowledge base that they'll have.
For sure, for sure. Well, wonderful. So Young, Jason, thank you guys so much for a fantastic presentation tonight. Thank you for taking the time to be here and answer our questions. Really, really appreciate this. It was informative and it was definitely needed. So thank you. One last thing for everybody. We have another upcoming sports economics webinar on October 1st. It'll be featuring Dr. Elliot Hugh and moderated by Sal Portugal. And it's going to be talking about patient satisfaction and job career implications. So stay tuned for that. And remember, this will be up on our YouTube web page or series page, sports economics through the AMSSM in a couple of days. So rewatch it if you didn't get a chance to watch. I hope you see it then. All right, everyone. Take care. Good night. Thank you for coming.